We're going to get started with our first case, and our presenter will be Dr. Craig Lemert, who is a clinical and research gastroenterologist and hepatologist at Indiana University, and his clinical interests include autoimmune liver disease, autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis. Thank you.
Great. Thank you, Dr. Price, and thank you for the event organizers for the invitation. And really pleased to stand up here and share a little bit about autoimmune hepatitis. I'm going to try to convince you today that AIH is having a little bit of a time right now. Maybe not so much as PSC and PBC, but again, I think we're primed and ready to explode. Hopefully from this talk, maybe you get a little bit more perspective in terms of some of the aspects that are changing in this field specifically in relations to maybe the needs that patients but also clinicians are seeing on a daily basis. So for this common consults for hepatology, I'm hoping that you leave today understanding that there are new clinically relevant endpoints we should all be targeting in the treatment of AIH that have good evidence-based outcome data with them. We're going to review some management principles and strategies and how they may apply to those that are newly diagnosed or chronically managed. And at the end, we'll talk a little bit about first, second line and beyond therapies as we go into treatment considerations. So because this is a consult talk, let's talk about a case. This is a patient of mine that's 61 years old that was referred to me because she was seen in her primary care doctor's clinic for routine health maintenance. She had noted an increase in daily fatigue really over the past 3 months or so, but had otherwise been reasonably healthy. Reports that were done in an urgent center about 4 weeks ago noted some increased liver tests. At that time, the urgent care physician said, well, based on some of your other comorbid conditions, probably fatty liver disease. But at that time, she was complaining of some nasal stuffiness and low-grade temperature. She was treated for an upper respiratory infection with amoxicillin clavulanate. Her past medical history, much like many others from the great state of Indiana, have type 2 diabetes for the past 8 years. That's reasonably controlled with hypertension, obesity with a BMI of 35, and hypothyroidism as well. Notable, after the visit, she goes and gets her labs. At that time, her ALT was 130, AST 143, a slight increase in her total protein with positive autoantibody markers, anti-smooth muscle antibody, anti-neutrophil antibody, as well as a mildly elevated IgG. Her viral markers were all negative. Beyond this workup, there was an ultrasound that was ordered that showed an increased echo texture. This showed concern for increased steatosis in the liver parenchyma, which in fact we also had seen in the clinic as well based on transient elastography performed with FibroScan. Her CAP score was 283 and her kilopascals was 11.3. Liver biopsy was then completed after this for concerns about diagnosis. As you can see from this biopsy, just to reiterate some important aspects, we see an enrichment of polymorphonuclear inflammatory cells near ballooned hepatocytes, consistent with a more lobular type of inflammation, but also with the arrows, as you can see, in interface hepatitis consistent of lymphoplasmacytic cells at the leading edge of this inflammation as well. So I'll just briefly say, when we diagnose autoimmune hepatitis, I think it's important to consider that this is a very heterogeneous disease that is really the result of genetic and environmental factors, much like other complicated autoimmune diseases. This is a female predominant with classic autoantibodies and HLA enrichment, particularly in genetic risk factors. We know this all results in failed immune tolerance. We then see a balance and change in homeostatic control, ultimately resulting in inflammation that drives fibrosis progression. We know that we actually can see this in all populations, age ranges, and ethnicities. Despite that we know that this is a female predominant disease, we still see males and non-white patients as well. And the presentations are important because they're variable. We see different treatment responses, outcomes. We ultimately know that some of these subgroups also have worse overall outcomes too. So when we consider the diagnosis of autoimmune hepatitis, I think I get asked often about what's the simplified criteria. And I think I'm going to go above and beyond this because I think any clinician in the room realizes we have to think about clinical presentation, biochemistries, the serologies, and histologic findings, even beyond the simplified criteria. As we know that they retain high specificity for the diagnosis of AIH, exceeding 95% for scores of 6 and 7 on that scale, but we also know that the sensitivity is somewhat limited, ranging anywhere from 50 to 95% depending on probable or definite diagnosis. So really, some of the more important linchpins of the diagnosis results in liver biopsy. I want to use this as just a general roadmap. This was recently published by Ansgar Lose, Journal of Hepatology, and I think it highlights kind of a nice pathway forward as we think about the treatment and management of these patients. And I also will highlight there are different thoughts in terms of EASL, but also AASLD guidelines and how we approach these up front. Ultimately, for patients with diagnosis, the initiation of steroids and a more European approach of 0.5 to 1 milligram per kilogram per dose with maybe a 2-week break before starting a steroid-sparing agent such as azathioprine or mycophenolate mofetil, whereas AASLD favors a more fixed dose approach using a combination of 30 milligrams per day with 50 milligrams of azathioprine. I'm going to tell you a lot more that this is not necessarily what I do in my practice, but again, at least a starting point for our discussion. As we consider these initial therapies, I think it's important to highlight that nearly 15% of patients will be intolerant to first-line therapies. I'm going to direct this more at azathioprine. And again, this aspect that we need to consider to change therapies beyond this if this becomes important. Recently, the International Autoimmune Hepatitis Group had highlighted some key endpoints that we need to see to understand the risk of progression. Non-response and a consensus statement is really less than 50% reduction within the first month. This seems to portend to increased risk of liver transplant and or death in those patients. So if that does happen, you do need to reassess the diagnosis as well as consider adherence, and you may need to be bumping up steroids or making a change from budesonide to prednisolone in that matter as well. We'll talk more about that. After this, I think certainly we need to think about optimizing baseline therapy. 6 months is a really critical endpoint for AIH, and again, based on consensus, but also good data now that we actually can see better improved transplant and survival outcomes if patients get normal liver tests and immunoglobulin G within 6 months. But unfortunately, only 40 to 60% of patients may have this biochemical remission, and an important aspect to highlight with patients as we follow them in the first 6 months of care. They then transition beyond this. If they lose remission, here at the bottom, we do need to, again, if we pull back corticosteroids too fast, we need to think about adding them back on, assess adherence, but also we may need to adapt their baseline steroid-sparing agents as well. But ultimately, we want to get into long-term remission. Again, low normal liver tests, including AST, ALT, and IgG. And ultimately, beyond 2 years, we need to think about possibly these patients that we can withdraw therapy. But I also want to highlight, as we are thinking about clinical trials, and I'll highlight some of these unmet needs, that liver histology is not necessarily incredibly important, even though this is much the gold standard. We are now seeing that patients will maintain histologic activity index even despite having normal liver tests. So again, the key part of this is our biomarkers are not completely well understood or excellent in understanding control of this disease. With withdrawal of therapy, again, if you're on therapy for at least 3 years, with 2 years of those being low normal liver tests, you can attempt to withdraw therapy, but unfortunately relapse happens in somewhere between 40 and 50% of patients based on small studies. Returning to our case, I think the really important aspect here is this is a form of variant syndrome, particularly now that we know that MASLD and MASH affect somewhere between 18 to 46% of Western countries. And it really establishes that this coexistent with other liver diseases is ultimately inevitable in their patients. And how do we consider this and how do we evaluate? So there's been different reports of impact of steatosis and steatohepatitis on concurrent AIH, and a recent European effort reinvestigated the prevalence and clinical significance of this co-syndrome, so to speak, in a large multicentric cohort of patients with autoimmune hepatitis. And what we found is in these 640 patients that nearly a quarter of patients had MASLD, of which 18% had AIH with steatosis and nearly 5% had AIH with MASH. Ultimately, what was found in terms of the clinical parameters is the patients with AIH and MASH were more frequently had cirrhosis at diagnosis. Interestingly, the treatment response for these patients did not differ between these two groups, but I do want to highlight that those patients with cirrhosis and combined fatty liver disease had higher frequency of decompensation. So again, it's important to treat these patients both for their AIH, consider therapies that may escalate their fatty liver disease, but also treat their fatty liver disease as well. One of the key findings from the study, which we also now are seeing in other diseases such as PBC, is patients with type 2 diabetes, independent of other factors, actually had a cumulative increase in hazard in terms of disease progression in the study. Ultimately, the same thing for dyslipidemia as well. So again, I think this raises a few concerns for myself, Particularly, I think the diagnosis of fatty liver disease and AIH is easier. My concern is diagnosing AIH in patients that have fatty liver disease unbeknownst to us. So it's clear that challenges in AIH remain, and again, taking an approach, as I'll highlight today, that we need to minimize steroid utilization. We need to identify treatment paradigms that actually normalize liver tests that are well tolerated. And then, in fact, one of the approaches that many industry partners are now looking at is managing the hard-to-treat patients, those patients that we cannot get normal, or those patients that maintain on at least moderate dose of corticosteroids. I want to speak to prednisone or budesonide specifically. Ultimately, based on guidelines, and I see a lot of cookie-cutter approaches, we are using high doses of corticosteroids, specifically prednisone and prednisolone, at disease onset when it's not necessarily needed. This was an important study from Pape and friends in Europe, specifically looking at patients with low or intermediate doses of corticosteroids for treatment versus higher doses of 0.5 milligrams per kilogram per day. And in comparison, we didn't nearly see any changes in biochemical remission. So in fact, I think it's important to think about where can we shave off corticosteroids in these patients, and that diagnosis actually may be a very important first step. Now, based on Michael Mann's study from 2010, there was a lot of interest in budesonide over the past few years, but many of us hepatologists also started to realize that budesonide may not be as effective as other systemic corticosteroids. For those in the room that aren't aware, budesonide has the benefit of having increased hepatic first pass metabolism, thereby minimizing systemic corticosteroid response. But we'll also say that maybe we don't fully understand the CYP systems, and in fact, there are some concerns about potential systemic release of budesonide in the setting of significant ongoing inflammation. Other considerations with budesonide is this would not be utilized in patients with cirrhosis or portal hypertension. And really what this study looked at was budesonide's utilization in comparison with azathioprine compared to patients with prednisone and azathioprine. And with this, we had 105 patients treated with budesonide as a first-line drug, whereas 276 patients were treated with prednisone. The efficacy was looked at using logistic regression and validated using inverse probability, but the biochemical remission rate was significantly higher in patients treated with prednisone. You can see in this first figure. The probability of achieving biochemical response assessed using inverse probability treatment weighting propensity score was significantly lower in the budesonide group at any time during the follow-up. And you can see specifically at 6 months, but also at 12 months as well. This highlights again that budesonide may not be as effective as prednisone in inducing remission. But in fact, in the study, there were some other thoughts, and this may be a little bit different than what you've heard or known. Based on the initial randomized controlled trial of budesonide, that budesonide was effective and superior, but it was more specifically for the endpoint. Specifically, the endpoint was biochemical remissions in the absence of adverse events. And unfortunately, systemic prednisone probably added to that component. But at least in this study, budesonide was just as efficacious as prednisone in the patients that had liver tests really below 2 times upper limit normal, where we see 70% of budesonide and prednisone patients did meet biochemical remission at that time as well. And really, in terms of adverse events, the other reassuring thing was in patients that were non-cirrhotic, the prednisone and budesonide groups were actually equally well tolerated. So when we think about treatments for AIH, how good are they, and what are we quoting to our patients when they are diagnosed? I think historically we've all considered that most patients, probably 80%, are able to get in remission here in this top left. But as we look at larger cohort studies, it's somewhere between 40 and 60%. And this is to meet remission at 6 months. We're also then seeing on the flip side of that is the patients that are having incomplete or partial response, which is incredibly important because these are the patients that have higher risk of fibrosis progression. Those patients that are intolerant, we do a great job if we switch from standard of care or azathioprine to any of these other alternative approaches, either second line or third line therapies. The more concern is related to the incomplete responders. I think before you make any changes and switches in these cohort, we do need to think about a few things, particularly adherence, other concurrent diagnoses such as MASLD, celiac disease, other variant syndromes, Wilson's, other drugs or drug-induced autoimmune like hepatitis, alcohol, and then making sure that you're optimizing patients' overall treatment course in terms of trying to minimize corticosteroid use. I put genetics in here too because there's some emerging data that PNPLA3 may also increase the risk of poor response and worse overall outcomes from 2 different cohorts as well. But as we get to think about rescue and incomplete or partial response, we can see that our other therapies don't do so well. And mycophenolate, despite this is part of the treatment paradigm, many of us reach for CellCept after azathioprine has not provided the response that we've wanted. Unfortunately, again, approximately 30% of patients will be able to regain response with that transition. Others have considered things such as tacrolimus, but even dual agent therapy. But again, the cohort of patients that are rescued still is reasonably low. And particularly, we're not measuring the amount of patients that are still requiring 5 to 10 milligrams of prednisone or budesonide as well. Other data has been looked at, particularly mTOR inhibitors, more recently the infliximab with some interesting data for response, and then rituximab as well with meaningful ALT reduction, but no necessarily decrease in substantial corticosteroid utilization. I have to be honest, these studies are all very small and leave a lot to be desired. More recently, we've now considered CellCept as first-line therapy of the Camaro trial. This 24-week prospective randomized open-label study from Europe looked at 70 patients. This would be with MMF plus prednisone or azathioprine plus prednisone. And what we found was the primary endpoint was met in 56% of patients assigned to the MMF group versus 29% of the azathioprine group, which actually is quite dismal if you think about it. The relative difference was about 27.4 percentage points. We see that the MMF group had a higher complete biochemical response rate at 6 months. There were no serious adverse events in the patients who received MMF, but serious adverse events were reported in 4 patients who received azathioprine. And I think really what we can take from the study is they were probably equally efficacious. It just seems in the intention to treat component of this is that MMF was much better tolerated than azathioprine. Leading to the question, if one of the challenges of moving to CellCept is because azathioprine does not work as first line, how can we optimize it? And it's funny to be here at a GI meeting talking about measuring metabolites for azathioprine, but this is something that's been highly contested over the past few years. We have a more definitive study now highlighting that sustained biochemical remission seems to be related to thioguanine metabolite levels, and this should be incorporated into your practice as you follow these patients as well. In this large study, there was 337 patients, and there were 146 of them that actually had multiple measurements. And you can see the chance of never complete biochemical remission or lost complete biochemical remission was much well correlated to the level of 6 thioguanine metabolites. In an area under the curve assessment, it seemed like the sweet spot for a sensitivity of 76% and specificity of 78% was a level around 223. And again, I've been targeting levels probably 250 and above to 300, knowing that more than 300 we get into more challenges with myelosuppression. But again, at least a target for our patients to make sure that azathioprine is optimized. One question I think about in my clinic often is, do you need to, when you have someone in complete remission, can you actually reduce azathioprine to the lowest effective dose? This study would actually suggest otherwise. And in fact, looking at patients that actually at baseline had biochemical remission but then subsequently lost remission, we found that their metabolite levels was much below that of 223. And often this led to many clinicians still reducing their levels even though they were losing remission. So again, these are similar principles that have been used in IBD over 20 years ago. They have just landed here in AIH and something that we need to be doing clinically. Outside of that, the ratio of MMPN to 6-TGN also may be important, as patients may be shunting to a non-viable pathway that controls immunosuppression. And it seems that the ratio of less than 5 is something to target to have the highest complete biochemical remission. This strategy is something, again, that I'm using in my clinic and highlighting with patients and seems to be relatively important. So when you are thinking about treating patients beyond standard of care, who are these cohorts that we should be thinking about? Obviously, patients that are intolerant to azathioprine, I'm still very surprised by the amount of intolerance I see. We also then see patients with therapeutic thiopurine levels that are there, but they are not meeting biochemical response. Therefore, we need to either add or go above and beyond. Those patients that are low metabolizers or even indeterminate ones may, for TPMT, should probably be considered beyond azathioprine as well. Shunting to MMP and pathway preferentially. Those patients that are on corticosteroids for long term to maintain normal liver tests. And I would actually argue any dose of corticosteroids should be considered as a reason to think about other agents. And then if you have another autoimmune disease that's managed with another therapy, such as a biologic, maybe you can move above and beyond standard of care. Just a few comments about some of the strategies we're using. I want you to remind you that the azathioprine dose changes. Takes 4 to 6 weeks of significant change. When we move to MMF, you have to think with patients about BID dosing, which is more problematic. It's really good in those patients that are intolerant, but the rescue effect is not dramatic. Also thinking 500, at least 1,000 milligrams per day, but I think more recommended 2,000 is where we need to be. But we have no drug targets. Despite you can check mycophenolate levels, this has not been utilized in clinical practice, nor do we know how it necessarily relates to overall outcomes. Just here finishing as well, tacrolimus or other CNIs, some things to think about this is trough levels below 8, but probably 3 to 5. Some other concerns about renal toxicity and maybe diabetogenic as well. Other biologics are also now up and coming and studying more in terms of infliximab in terms of overall response. But I think highlighting these needs is the idea that clinical trials in patients that are not fitting with this, we need to think about novel agents and other cell-based studies. And again, if you have patients that fit into these categories, with industry partners now interested in this disease state, we should be considering these. So in summary, I want to highlight that AIH-related endpoints, specifically biochemical response at 6 months, are highly predictive of liver transplant-free survival and overall outcomes. This should be our target, but please take a nuanced and thoughtful approach to AIH. That means minimizing steroid utilization, looking for side effects, and trying to optimize these current regimens as well. And it's imperative, particularly as we await better therapies. And finally, multiple agents beyond azathioprine can be considered for AIH. So don't get stuck on azathioprine, but consider other approaches. And in fact, when in doubt, refer to a larger academic transplant center. Thank you so much.
Thank you for that amazing talk. So our next speaker is Arun Jasudian, who is an associate professor at Cornell, where he directs the liver quality and inpatient liver services. He serves as a member of the ASLD Practice Metrics Committee and is a site PI for the Cirrhosis Quality Collaborative. And he will be walking us through the next case.
Thank you very much. So we'll change gears just a little bit to talk about another autoimmune liver condition, primary biliary cholangitis, and specifically, how might you manage a patient who has not responded to ursodiol? So over the course of this presentation, I would like to start with just some PBC basics to make sure we're all on the same page, and mention ursodiol itself, the rationale for its use and the data behind its effectiveness, and really importantly, focus on the definition of non-response. When do we determine that a patient has not responded to ursodiol therapy, and how do we determine that they are a non-responder? And close by introducing second-line options for this patient who, in terms of the consult, is an ursodiol non-responder. So primary biliary cholangitis, as I'm sure you are aware, is a progressive cholestatic liver disease that is autoimmune in nature. It's characterized by T-cell mediated destruction of the microscopic or the intralobular bile ducts, and that leads to this retention of bile acids, and over time fibrosis and eventually cirrhosis. Just in terms of epidemiology, depending on the studies you look at, the female to male ratio is somewhere around 9-to-1 to 10-to-1, so clearly many more women with PBC. But 10% of the cases, about 10%, do occur in men, and these are often more aggressive in terms of their clinical course. PBC typically presents after the age of 40. The median age of diagnosis is 50, and about 1 in 1,000 women over the age of 40 are living with PBC. That prevalence has been increasing over time, currently around 40 out of 100,000. And I can say in my clinical practice, I'm seeing more PBC anecdotally on a week-to-week basis. To make the diagnosis, this comes from the ASLD guidance, you need 2 of these 3 criteria. So biochemical evidence of cholestasis, so usually you're looking at elevated alkaline phosphatase. the presence of an anti-mitochondrial or an AMA antibody. There are some cases of AMA negative PBC, and there are some other autoantibodies you could send in that situation, like SP100 or GP210, and or a liver biopsy that shows you these features of primary biliary cholangitis. Now, the biopsy is not required if you meet the other two criteria, elevated alkaline phosphatase and elevated AMA. Our goals of any treatment, be that ursodiol or second-line treatment, is to prevent disease progression, to preserve that patient's liver function, to reduce their need for a liver transplant, their risk of dying related to consequences of PBC leading to end-stage liver disease, and also importantly to address their symptoms, be that fatigue or pruritus or other associated symptoms. The ASLD guidance gives us an algorithm here, starting with that diagnosis, which we just reviewed. Remember, 2 out of the 3 criteria clinch that diagnosis for you. It's important to stage the degree of fibrosis in that patient. So if you had not obtained a biopsy, this is the time to obtain either an elastography or potentially serum-based non-invasive testing, if that is what is available to you, to know the fibrosis stage. And the first-line treatment is, of course, ursodiol, weight-based, 13 to 15 milligrams per kilogram daily, dosed in divided doses. And let's focus on ursodiol in terms of why we use it for PBC. So ursodeoxycholic acid is administered orally. It is a naturally occurring hydrophilic secondary bile acid. Again, that dose is weight-based, 13 to 15 milligrams per kilogram daily. Twice daily dosing is all you really need to do. It's much easier for the patients to take that way instead of 3 times a day. You can see improvement in the liver biochemistries within a few weeks, and most of that improvement should occur by about month 6 of therapy. Now, importantly, up to 40%, and in some studies you might see up to 50% of patients with PBC have a suboptimal response to ursodiol and should be considered for second-line therapy. So first, how do we determine a response? You'll see a number of criteria here that have been used. Perhaps the most widely utilized in clinical trials has been the Toronto criteria, looking at an alkaline phosphatase that improves to less than 1.67 times the upper limit of normal. But I will ask the question whether that is sufficient, and this is an important point when it comes to managing your patients with PBC. Is an alkaline phosphatase that has improved but is not completely normal sufficient? So we see here that in patients who have an alkaline phosphatase anywhere above the upper limit of normal, they have a 2 times greater risk of requiring a transplant or dying versus those who had alkaline phosphatase normalization. This is over 3 years of follow-up. And so what I will give you as a take-home message here is that there is a compelling case to be made for normalization of alkaline phosphatase being your goal of treating your patients with primary biliary cholangitis, as opposed to just improvement beyond a certain threshold because of this association with hard outcomes related to this chronic condition. So back to the guidance. It tells us to assess the biochemical response in terms of liver enzymes at the end of a year of ursodiol therapy. And I again will ask a question whether this is sufficient. There is a case to be made here for assessing that response earlier than 1 year at 6 months, and specifically looking at whether the alkaline phosphatase has improved to 1.9 times the upper limit of normal or better. The reason being, and you can see that here, that in patients who improved over the course of 6 months of therapy and their alkaline phosphatase was less than or equal to 1.9 times the upper limit of normal, 80% of them went on to respond fully at a year. On the other hand, the patients who at 6 months had not met that threshold, very few of them, 11%, were then responding at the end of a year. So you do not necessarily have to wait a full 12 months of ursodiol therapy to determine that patient is a non-responder. You could, based on this evidence, say at 6 months, I'd like to see whether this is 1.9 times the upper limit of normal or better. And then if they're not responding, consider your second line therapy at that point. So I'll introduce a case here. It's a 43-year-old woman who presents with fatigue, and she has a pretty markedly elevated alkaline phosphatase of 530. Not all patients present with this high in alk phos, but certainly some of them do. She does have a positive AMA, and she happened to have a liver biopsy, which is consistent with PBC stage 2. Started on weight-based ursodiol, and at 6 months, her alkaline phosphatase has improved, but is still 390, and so we'll revisit her in a little bit. So in a patient who has not responded at the end of a year, according to this algorithm, or potentially 6 months, as we just reviewed, one question to ask yourself is, am I missing a different superimposed condition? So for example, MASLD, looking for cardiometabolic risk factors, steatosis on imaging, or potentially autoimmune hepatitis overlap, which we just reviewed in that fantastic talk before mine. There are criteria to help you identify autoimmune PBC overlap if your patient meets 2 of the following criteria. So the ALT is markedly elevated, 5 times the upper limit of normal. The IgG level is twice the upper limit of normal, or if you see a positive anti-smooth muscle antibody, and of course, if you see a liver biopsy with features of autoimmune hepatitis, such as interface hepatitis. So once you've excluded that and you feel confident that this patient has not fully responded to ursodiol, that's when we talk about second-line therapy. So FDA-approved second-line therapies, there are a few of them: obeticholic acid or OCA, elafibranor, seladelpar, and for all of these agents, they're used in combination with ursodeoxycholic acid when there's a suboptimal response to the urso alone, or can be used as monotherapy in patients who are intolerant of urso. All of them are contraindicated in patients with decompensated cirrhosis. Obeticholic acid, or OCA, is a farnesoid X receptor agonist, which decreases bile acid synthesis and increases secretion. It does cause in some patients pruritus as its main side effect, which is dose dependent. Now, importantly, the FDA has issued some commentaries recently regarding OCA. So the FDA Advisory Committee voted against the approval of OCA in PBC without cirrhosis or compensated cirrhosis because of concerns for hepatotoxicity, or what they call real possible harm. That was in September of this past year. And in November, they declined full approval of OCA pending additional trials, verifying the benefits. So I think it's safe to say at this point in time, OCA has fallen out of favor a bit because of these concerns for hepatotoxicity, pruritus being a side effect, and also that we do have 2 newer FDA-approved therapies that do not have those same adverse event concerns. So these 2 new therapies are from the class of PPARs, or peroxisome proliferator activated receptor agonists, PPAR agonists. And PPARs in general are nuclear receptors that play a role in the regulation of transcription genes that are involved in inflammation, carcinogenesis, and metabolic pathways. So you see here PPAR alpha, gamma, delta. The 2 PPARs that are currently FDA approved are elafibranor and seladelpar. Elafibranor is a combined alpha-delta agonist. Seladelpar is a delta agonist. And we'll go through their data a little bit as it pertains to this case or any patient who has not responded to ursodiol. So elafibranor, this is the ELATIVE trial, included just over 160 patients with PBC. They had an alkaline phosphatase 1.67 times or higher, above the upper limit of normal, and a bili that was generally normal after at least a year on ursodiol therapy, so an ursodiol non-responder. Randomized 2-to-1 to the elafibranor 80 milligrams for a year, and then followed in an open label extension. Primary endpoints were the alkaline phosphatase decreasing below that threshold, decreasing at least 15%, and the bilirubin remaining normal or staying normal. Also looked at whether patients had normalization of their alkaline phosphatase and a few different pruritus or itchy scores, and also just the change in alkaline phosphatase overall. Take home from this trial is, again, elafibranor is a PPAR alpha and delta agonist. This is the phase 3 ELATIVE trial. 51% of patients, again, ursodiol non-responders for at least a year of therapy, 51% met that primary endpoint, that composite type of endpoint. 15% had normalization of alkaline phosphatase. And that might not sound like a huge number, but what I'll tell you is that these patients had a mean alkaline phosphatase of around 320, so they were pretty advanced in terms of their PBC. And also for this trial, the sponsor used as normal alkaline phosphatase for women a value of 104. So it was a pretty strict definition of normalization. And so it is somewhat impressive that this many patients met the normalization at a year starting that high and meeting an alk phos of 104. They did see numerical improvement in one of the pruritus scales, the worst itch scale, that didn't quite meet the level of statistical significance. Seladelpar, this is the response trial. This was 193 patients with PBC and similarly had non-response to ursodiol at the end of a year or more and had normal bilirubin to be entered into the trial. And we're looking at very similar outcomes and very similar design. They were randomized 2-to-1. This was seladelpar 10 milligrams given over the course of a year, and there is an open label extension. Also looking in terms of secondary endpoints at alkaline phosphatase normalization, pruritus improvement, and change in alk phos. So here, the top line summary from the response trial. Again, this is a PPAR delta agonist. 62% in this trial met that composite endpoint. 25% saw normalization of their alkaline phosphatase. And they did notice statistically significant improvement in pruritus using that worst itch scale. So revisiting this case, this patient who had non-responded to ursodiol, this is certainly someone you would want to treat with one of these two newly FDA-approved PPAR therapies added to the ursodiol, provided that this patient was tolerating it, and there's no suggestion that she wasn't. And again, you could potentially determine the non-response as early as 6 months. So in summary, around 40% of patients with PBC do not respond to ursodiol therapy. You can determine that response as early as 6 months on therapy. Remember, 1.9 times the upper limit of normal or better is a response at 6 months. Ideally, you want your patients to see normalization of alkaline phosphatase in terms of preventing those outcomes like requiring liver transplant or potentially even death related to their liver disease. If you do not see a response to ursodiol, remember to exclude other processes, including MASLD, including autoimmune hepatitis, if the liver enzymes are markedly elevated or the IgG is elevated. Second-line PPAR therapies, elafibranor and seladelpar, are used in addition to ursodiol. So unless someone is intolerant, you'll want to use them together. And you see across these two trials, 50 to 60% biochemical response at the end of a year of starting the second-line therapy, and a 15 to 25% likelihood of normalizing alkaline phosphatase on therapy. Thank you very much.
Thank you, Dr. Jasudian. That was excellent. Now we'll have Dr. Winston Dunn from University of Kansas with a patient with mast cell asking about approved medications.
Thank you, Mark, for the kind introduction. I would like to thank AGA and Dr. Sengel for the invitation. The FDA has approved resmetirom for patients with MASH and F2, that is significant fibrosis, and F3, advanced fibrosis. Many providers, like ourselves, as well as our patients, may have some questions about the approved medications. So I have come up with a few, and I'm going to go through these questions with you one by one. So the first question is who should be screened with the imaging tests such as VCTE or serological tests such as ELF. Let's quickly go through the AGA guideline. The AGA guideline starts with the primary screening test, which is the FIT4 score. Patients with a low-risk FIT4 score can continue to be managed by the PCP, while intermediate risk, defined as between 1.3 to 2.67, should undergo a secondary risk assessment, that is with a VCTE. It is suggested that patients with a high-risk FIT4 score greater than 2.67 should be directly referred to a hepatologist or gastroenterologist. The AASLD guidelines build upon the previous guideline with the following additions. For instance, it is pointed out that for secondary risk assessment, we can use the ELF in addition to the VCTE. It is also pointed out that in the GI and hepatology office, we have the options of using the primary assessment tools, that is the FIT4, as well as with the secondary risk assessment tool, that is with the VCTE or with the ELF, as well as with the more advanced imaging techniques such as with MRE and CT1. It is also pointed out that in patients with elevated liver enzyme to start with, these patients should be directly referred to GI and hepatology. So the target for screening has been shifted with the new FDA approval. The traditional screening is for advanced fibrosis. These patients are immediately at risk for liver-related events. With the new approval for patients with significant and advanced fibrosis, we are trying to identify patients with earlier stage disease and intervene on these patients earlier. So let's see how the FIT4 score is doing in identifying patients with significant fibrosis. We learned that from the MESO-NASH trial on the right that the median FIT4 score is 1.3. Now, just a refreshment of your high school statistical lesson, that if the median FIT4 score is 1.3 and you use 1.3 as a cutoff, you will miss exactly 50% of the patient. On the left-hand side, it is a cohort that we have put together from 6 centers with 450 patients currently being treated with resmetirom, a real-world cohort. In that cohort, if we apply the FIT4 score of 1.3, we find that exactly 45.8% of the patients would have been missed for and not have further evaluation. What about some of the more novel scores? SAFE score is a score that has been published from Ray Kim's group from Stanford recently. The score used age, BMI, diabetes, AST, ALT, globulin, and platelet. Of note, globulin is just a subtraction between the protoprotein and albumin. This score is available online, and by applying the SAFE score to our cohort, we are able to include all but 13% of the patients. This is our recent publications in American Journal of Gastroenterology, a novel score called Aladdin F2 Lab. This score uses additional parameters, including the lipid panel and the GGT, that is in addition to the parameters used by the SAFE score. And it is from 15 centers using 4,300 patients with liver biopsy as the reference standard. In the external validation cohort, we show that it is more accurate than FIT4, SAFE, and liver risk score. And we also have an online calculator that you can use. Now, this slide is available online, and if you use your phone to scan this QR code, you can access our online calculator directly. Now, using the cohort that I mentioned previously, by applying the Aladdin F2 lab, we will include all but 12% of the patients. Going to the next question, so who would qualify for the resmetirom? This was discussed in the expert panel published in 2024, as well as the AASLD guidance in 2025, and I'll go through both with you. The expert panel mentioned cut points based on VCTE, MRE, and ELF. And of note, the VCTE cut point was selected to be between 10 and 15 because that was the interquartile range that was in the meso-MASH trial. Now, for the ELF, I would like to point out that for patients with ELF of 9.8 to 10.4, patients would qualify for treatment. However, between 9.2 to 9.7, these patients would need additional evidence. I would also like to point out that there is an expanded criteria that is in the yellow zone, that is patients with a higher liver stiffness, but not, or liver stiffness or ELF, but not quite reaching the cirrhosis. These patients can still be treated with resmetirom at the judgment of the treating gastroenterologist or hepatologist. Now, I would like to point out what is the key difference in the AASLD guidance from the expert panel. Now, note that the decision to use the VCTE cut point from 10 to 15 is based on the interquartile range. Now, another statistical lesson. So if you choose the 10 to 15 based on the interquartile range, you will miss exactly 50% of the patients because they are outside the interquartile range. For that reason, the AASLD guidance decide to choose 8 to 15 instead of 10 to 15. It also choose a lower cut point for MRE at 3.1 to 4.4. The AASLD guidance did not give exact recommendations on the ELF. It also have a expanded zone that is in yellow, similar to the expert panel. Now, the next question is who should be excluded? It is important to note that the FDA did not approve resmetirom for patients with cirrhosis. Therefore, patients with cirrhosis should not be treated. And both the AASLD guidance and the expert panel has agreed that patients with VCTE greater than 20 kilopascal and MRE greater than 5 kilopascal should not be treated because they have cirrhosis. The expert panel use an ELF of greater than 11.3 as the cut point for cirrhosis. The next question is, what if we are mistaken in our staging and we inadvertently included patients with cirrhosis? Well, this is a press release from Magical. It shows that in the 130 patients that was treated in the Mastro-NAFLD 1, there is a median decrease of 6.7 kilopascal in the liver stiffness. And of note, 51% of the patients actually achieved at least a 25% reduction in liver stiffness. These patients would have a reduced risk of progression to a liver event. Now, seeing that the use of resmetirom in these patients are probably safe, but it is important to note that our intention should always to include patients with F2 and F3 fibrosis. And if we inadvertently include a patient with cirrhosis, it is probably safe. If our intention is to include patients with cirrhosis, with compensated cirrhosis, we will inadvertently include patients with decompensated cirrhosis, and there is absolutely no safety data in this area. Therefore, I must emphasize that our intention must be to include patients with significant and advanced fibrosis, not cirrhosis. So how should patients be followed? Patients should have liver enzymes on a quarterly basis. Now, it is important to note that the ALT may have a bump in the first month when the patient is on concurrent statin treatment. This bump typically will go away on the second month, and therefore it is not recommended that you have a liver enzyme checked on the first month. It is recommended that you just have liver enzyme checked on a quarterly basis to avoid unnecessary panic and consultation. In addition, liver stiffness, that is either with VCTE or MRE, should be measured at baseline and at the end of the year to assess efficacy. It is optional whether you want to measure liver fat with MRI-PDFF in the baseline and at the end of the year. So what should we be looking for? We should look for ALT either normalization or substantial improvement. And with VCTE, we are looking for a 25% drop. And with MRE, we are looking for a 20% drop. With MRI-PDFF fat improvement, 30%, it is a very sensitive marker for histological improvement, but it is not always specific. So will it improve quality of life? This is a quality of life study that was published in the Hepatology by Dr. Yunasi's group. It showed that patients in the meso-NASH trial undergo two liver-specific quality of life, and they have demonstrated improvements in both quality of life related to emotional and physical health. And specifically comparing responder to non-responder, there is improvement in worry, health distress, low emotional, and stigmata. It is also important to note that comparing patients with advanced fibrosis to significant fibrosis, those with advanced fibrosis at baseline appears to have more improvement. What about concurrent alcohol use? In the meso-NASH trial, the intention is to include patients with MASLD, that is men drinking up to 2 drinks a day and women drinking up to 1.5 drinks a day. However, there are patients that may have drinks more than that based on the biochemical testing of CDT greater than 2.5%, or PEF testing greater than 20% that is noted at baseline and during the study. Those patients are already included in the study and not excluded. So in this analysis, patients are compared included as a MAT-ALD subgroup and compared to the MASLD subgroup. The MAT-ALD subgroup are younger, more likely to be male, less likely to have diabetes, and have a slightly higher rate of advanced fibrosis at baseline. If we look at the outcome in terms of MASH resolution and fibrosis improvements, or MRI-PDFF fat reductions, we see that the outcome is very similar across the MASH and MAT. Comparing the MASH and MAT-ALD groups. So what about concurrent GLP-1 receptor agonist use? In the meso-NASH trial, 2/3 of the patients have diabetes, and a total of 17% of the patients are on GLP-1, and also 17% are on SGLT2 as well. Now, those patients must be on a stable dose for 6 months prior to the enrollment into the trial. And they must also have the criteria that they cannot lose more than 5% of their weight in the 6 months prior to their enrollment. So here is the result in terms of MASH resolutions and fibrosis improvement. There is actually no difference whether they are on concomitant GLP-1 or SGLT2. Now, weight, on the other hand, is actually a major contributor to a successful outcome. If a participant is able to lose greater than 5% of their weight, they will have a better response compared to participants who are not able to lose 5% of their body weight. Now, as I mentioned earlier, for patients to be on a GLP-1, they must be on a stable dose for 6 months, and they must not lose 5% of their weight prior. Therefore, the amount of weight loss during the study in those on and not on GLP-1 is exactly the same. So in summary, so who are the patients that should undergo screening testing? Well, we previously have the FIT4, but we additionally have novel testing with SAFE and Aladdin Lab. And who would qualify and who should be excluded? We can use VCTE, ELF, and MRE. And if staging is missed, what would happen? Well, the patient is probably safe, but we emphasize that our intention should be for F2 and F3. How should patient be followed? We talk about liver enzymes and elastography. Would it improve the quality of life? The answer is yes. Is concurrent alcohol use compatible? The answer is yes. Is concurrent GLP-1 agonist use compatible? And the answer is yes. Sorry, 22 seconds.
Thank you, Dr. Dunn. That was excellent. Next, we will have a real expert in alcohol-associated liver disease, Dr. Singhal from University of Louisville, talk about is my patient with alcohol-associated liver disease and cirrhosis a liver transplant candidate? And a reminder that we'll take questions afterwards, and if the presenters can work their way up to the stage at the end of this talk.
Thank you, Mark and Jennifer, for inviting me to give this talk. As chairpersons of this session, I'm happy to be here. Good morning, everyone. And then start with the consult. We were invited to make a decision on liver transplant candidacy. So here are my disclosures. None of them is related to the talk. Related to the presentation, there's one disclosure I would make here is whatever I'm going to say is not coming from me as an individual or a hepatologist. That's going to be a team decision, as we all know. And a lot of members go into that team, including the paramedical staff, including your coordinators. The most junior person in the team, like a resident, has his voice and should have his voice in making that decision making whether the patient is an ideal candidate for liver transplant when it comes to alcohol-associated liver disease. So this slide I will go over some of the phenotypes of alcohol-associated liver disease which could go for liver transplantation. For example, the most common we all see patients who can be asked for transplant candidacy is chronic decompensated cirrhosis from alcohol. But we see this in acute insult and patient presenting rapidly with acute and chronic liver failure and multi-organ liver failure, either from infection most commonly, and infection most likely if it recovers, majority of them will come back to their baseline. You may not even need a transplant at that point of time, or if infection is uncontrolled, the patient has a high risk of dying, especially if it is multi-drug resistant infection. The second most common precipitant, which I think makes it more difficult to make a candidate selection, is alcohol-associated hepatitis. So I think if we take all those three phenotypes, cirrhosis, multi-organ failure, and alcohol-associated hepatitis, and we'll go back and forth and talking about the candidates in these settings. So in a cirrhosis patient, we know that MELD drives, and if this is the risk of dying with versus without transplant, we see at about 17 or 18 or higher, you start getting the benefit that you are reducing the risk of dying at that MELD score with a transplant versus without a transplant. But then we know that there are certain presentations or phenotypes which may not follow that MELD rule, and MELD exceptions are there, which we are all aware, and those drive independently the transplant evaluation and selection. So this slide is, I'll spend a little bit time here to talk about why MELD-based allocation may not be, although we still use it in the setting of multi-organ failure and ACLF, but may not be the ideal one. And we had that opportunity to analyzed the UNOS database about 3-4 years ago. And on the top side, you see the bars at a MELD of 10, 15, 20, 25, 30, 35, and 40. All of these bars show you a common finding that higher the grade of MELDs, the ACLF grade, the risk of dying is higher, because we know higher the grade of ACLF, the risk of waitlist mortality is higher. But what you can see here, when it comes to a lower grades of MELD, that hazard ratio of dying on the waitlist mortality is much higher compared to at a higher MELD score. You see that bars are going down when the MELD score goes up. So the risk of dying at a higher ACLF grade is much higher compared to a lower grade at a lower MELD score. In other words, I think the message from this slide could be the MELD-based allocation may be causing a kind of disadvantage when the MELD is low, but the patient is in high-grade ACLF. And that kind of disparity does exist in our practices, especially when we see these patients in ICU. And we know how to grade the ACLF, and this is again the EASL-based, which is what we used in that particular paper, with the liver failure, cerebral failure, coagulation, circulation, lungs, and other organ failure. And when the grade of ACLF goes up, we know the mortality goes up from 28-day mortality from 20% to almost 100%, and the person has all the 6 organ failures. But the liver transplant does provide benefit if we have very highly select patients with ACLF multi-organ failure. For example, in this meta-analysis, which was one of our fellows did it 2 or 3 years ago, probably 5 years ago actually, and shows you when they put together these multiple studies, all observational, no randomized controlled trials here, and showing you almost a 70-fold benefit if you do a transplant in this group versus no transplant. And that benefit persisted at 1 year for 70-fold, at 30 days about 32-folds higher if you get a transplant for ACLF versus if you don't do a transplant. So highly select patients should be transplanted for that. And what are the criteria? And that's where the fluidity comes, and selection criteria are not very objective. And these are very not evidence-based, but consensus by experts who deal with ACLF patients more than anybody else. And these are the criteria come forward that you may have a moderate kind of respiratory failure with PaO2 FiO2 ratio of 150 or higher. You should have negative blood cultures, no or maybe 1 vasopressor, a lactate level of less than 9. You should not be having an active GI bleeding, and you should have a moderate functional status of the patient. So those are the criteria which are usually followed if you have to make a decision on transplant in ACLF. What about the post-transplant outcomes? And we know that if you transplant patients with ACLF, their post-transplant outcomes are not similar to when you transplant a stable cirrhotic patient. And this is, again, we had the opportunity to look at the UNOS database, and we came up with this score using the demographics and some of the organ failures, and the 3 organ failures which were most relevant in driving the post-transplant outcomes were lung failure, brain failure, and circulatory failure. And using that score, these 3 tertiles could be low risk of dying post-transplant, immediate risk of dying post-transplant, and a high risk of dying post-transplant. And on the left-hand side, you would see when we took an internal validation data set, and across the deciles of this score here, there was good calibration of the score from the training data set to the testing data set. So the score was, I don't remember the C statistics, but was fairly accurate. But when it comes to what kind of graft you will use for a patient who is being transplanted for acute and chronic liver failure, again, using the same data, we classified the organ graft or the graft quality based on a donor risk index below 1.5 as a good graft, or 1.5 or higher as a poor graft. So these are the low-risk patients based on the score I showed you earlier on the slide. These are the moderate risk patients of dying post-transplant. Doesn't matter what kind of graft you use, but if it is a high risk of dying post-transplant based on the score we saw that in the previous slide, it matters, that if you give a good graft, the chances of survival are better compared to a poor graft. But how long can you wait? Then we had the further analysis of that database to see how long can you wait for because the therapeutic window or the window of that waitlist mortality is very, very short in patients who are in ICU with multi-organ failure. So then we looked at, and the cutoff was, were we waiting for 24 hours, 48 hours, and up to 7 days for a good graft for that high-risk population. And on the last column, you see that the donor risk index, which is the poor graft, which is 1.5 or higher, it doesn't matter how long you wait. Day 1 to day 7 doesn't matter the outcome. But if you're waiting for a good graft, which is the idea you want to give to these high-risk patients, is up to 48 hours, you make a difference in the wait lists on the post-transplant survival. So if you're waiting for up to 48 hours, but beyond that, it doesn't matter. But what matters beyond that you're increasing the waitlist mortality. So the message from this analysis was that if it is a low risk or moderate risk of dying post-transplant, doesn't matter, you can use any graft, the high risk of dying post-transplant, you may want to wait for 48 hours for a good graft, but if you don't get, then go ahead and transplant the patient, because otherwise the risk of dying is so much on the waitlist mortality. But then you should also be cognizant of certain medical issues in alcohol-associated liver disease cirrhosis patients. We all know that encephalopathy may not be typical. You may be picking patients with withdrawal wernicase or subdural hematoma. You don't want to do that. Neurologically, some of the things which may not improve after transplant, like neuropathy, cerebral degeneration, and then some of the other organ issues which we are aware of, heart, blood, and GI tract. Alcohol-associated liver disease, especially cirrhosis, we know has a pretty good outcomes post-transplant. This is database almost more than 10 years ago, but I think it still applies. Over 80% survival benefit, close to 90% at 1 year and 80% higher at 3 years, and close to 80% at 5 years, and 10 years is still more than 70%. And one of the reasons is that the acute cellular rejection in ALD patients is pretty low compared to other common indications like other previous speakers mentioned, an autoimmune disease, and used to be hepatitis C also, but now hepatitis C has a much better outcome. But one thing which remains, and that's where the conundrum comes in patient selection, is the relapse to alcohol use and its impact on patient and graft survival. So alcohol relapse after transplantation for ALD still remains about 2.5% per year. And so anybody 3 years later, about 7 to 8%. And then significant alcohol use or heavy alcohol use after transplantation does impact the graft with steatohepatitis, cirrhosis, close to about 8 to 10-fold higher. Recurrent alcoholic cirrhosis, if you take the overall cohort, was about 2%, but heavy drinkers is about 30%. So 1/3 of patients will lose their graft from recurrent alcoholic cirrhosis and may die. But the other cause of death in the long term at 5 to 10 years are malignancies, especially of your upper respiratory tract, larynx, esophagus, and the oral cavity, especially those who are also smokers. So therefore, it has to have a very good psychosocial assessment, which every transplant candidate goes through, which is more relevant in alcohol-associated liver disease. And I think this is a very neat study. And this is the 200 patients of ALD who were evaluated, almost half were declined. And the non-ALD of about 160, about 30% were declined. So the declination was much more in an alcohol setting. But it's mostly from the psychosocial standpoint. But if you look at their MELD scores, which is the medical eligibility criteria, there was no difference between the ALD patients and the non-ALD patients. It's psychosocial evaluation and support system which drives the selection in patients with alcohol-associated liver disease. So that brings us to the concept of how soon the patient should stop drinking or how far the patient should stop drinking. 30 years ago when alcohol became or more than 30 years ago when alcohol became acceptable etiology for liver transplantation, they came up with the 6 months criteria for abstinence because they wanted to allow the healing of the liver from the acute effects of alcohol, that it became like a rule for liver transplantation for alcohol-associated liver disease. If we look at multiple studies, and this is a systematic review for predicting alcohol relapse after transplant, and several factors listed in this table on the left you see. We look at the 6 months pre-transplant abstinence, only 2 out of the 11 studies could predict it. What came more important was the social support, the younger age, the coexisting mental disorders, and the failed previous treatment. Those were more important. And based on that, the 6 months rule was challenged almost a decade and a half ago by the French group and showed in a prospective trial that early liver transplant in a very high select population. And since then, retrospective, observational, small prospective studies have come. And this is a meta-analysis which one of our friends from Belgium did and showed that if you do an early liver transplant, even in those patients who don't have 6 months of abstinence, compared to no transplant, you get our 17-fold improved survival post-transplant or for the patient. So clearly in that highly select population, again, that brings us to how to select that population, and that is still where the problem is. So based on these data evolving over time, so 2018 EASL brought up that it should be considered in highly select patients. 2020 AASLD came up guidance, and in 2024 ACG came up with guidance. So all societies started recommending early liver transplantation for patients with alcohol-associated liver disease who are actively drinking or have not obtained a 6 months sobriety. But still remains how to predict or capture those patients who are not going to relapse with alcohol after transplantation. Multiple scoring systems. I picked one here from SALT score from the Accelerate Consortium in America, and the scoring parameters are here, the scores are here, a total score of 11, and you see on the left hand side the score 5, 6, 7, 8, 9, 10 and 11. The negative predictive value, as you see here, is pretty good. So you can exclude patients who are not going to relapse. But its positive predictive value is so poor. Even in the worst group with the highest score of 11, it's like flipping the coin. So that's the problem with most of these scores. You cannot pick up, the sensitivity is so low of that particular score. French group came again with another study, quick trans study, where they did the same model but now more objective evaluation of patients using the psychosocial evaluation, and out of a maximum of 250, they have to have a distinctive score of 220 or higher. So very rigorous case selection. Although the patient survival was similar, but when you look at the alcohol relapse, even with that objective, very strict, rigorous case selection, you see 4 times higher heavy drinking in early liver transplant patients compared to a standard cirrhotic more than 6 months of abstinence. So I think that's where the fluid zone is, how to select that population. That's why you see so much of heterogeneity across centers, across providers. You have a patient at your center, you say, I don't want to transplant this patient. Next door, the patient gets transplanted. So I'll give you a couple of cases here, just because this is a consult based. So 38 white male admitted with severe AH, 34 mild, no cirrhosis. He tried steroid, didn't work. No, this is a first decompensation. No major comorbidities. He's got a fair amount of drinking, no other substance use, and he has got an excellent social support, and he has not had any failed rehabilitation treatment in the past. So just 1 DUI. So this case, I don't think is a brainer. Anybody in any transplant center would be a low risk of relapse and will go for transplantation. Second case, now this patient has hepatorenal syndrome, mild is even higher. This patient has cirrhosis, ascites, is significant psychiatric comorbidities here, very high heavy drinking here, active at the time of admission, also uses marijuana, is unmarried, so social support system is not that great, and he has a court order rehabilitation where he stayed sober for 8 months. So this is a case where some centers might say we will not transplant, some centers might transplant, okay? So I think Gene did a very nice survey, and the survey was for the audience like this in 2 different meetings. One was in Seattle, one was in Philadelphia. And he showed 4 cases here, and the outcome of each case after transplant is listed in the second column. What he examined the various scores, including the Dallas conference, the SALT score, the CPAT score, and a quick trans. Even the quick trans, which I just showed you, the most rigorous one, you could see the consensus among the providers sitting in the audience in both the conferences was much better predictor of what happens after transplantation. The message from this is that even in our transplant centers, if you listen to everybody rather than having a dominant voice, which some transplant centers do, will automatically pick the right kind of patient. Still, you get a more objective protocol selection for these patients. So this is how we do currently. If you have a low risk of relapse based on so many, most of them are subjective criteria, I think. If you have a low risk of relapse and the social worker and addiction person does that, you list the patient. Very high risk, you reject, but in moderate risk is where the conundrum is, and then you can have an exception pathway. Some centers and some centers might refuse. So how patients should actually be monitored very nicely while they're evaluated for transplantation. So what happens in most centers is the patient is evaluated, and then once the patient is listed, the addiction social worker go their way. The patient comes to transplant clinic while they're waiting, and the post-transplant follow-up, there is no addiction follow-up. The true integration should be once the patient, the social worker and addiction team gets involved here, it should be followed through till the end and even the post-transplant follow-up. And that's the dream. Centers don't do it, most centers. Some centers who do it, they have very good outcomes. So summarizing, the patient selection for a patient with decompensated cirrhosis is like any other etiology, but you should recognize the unique medical issues these patients may have. For patients with ACLF and multiple organ failure, we need selection criteria which are objective and evidence-based. That's where the field lacks. There is an unmet need, and so is for patients for early liver transplant for alcohol-associated liver disease who are decompensated. So I will stop here and acknowledge my collaborators, funding, and patients and coordinators who recruit patients. And thank you very much for patient listening.
Thank you. If the presenters can come to the up front, and then please we'll take questions from the podium. Dr. Price will also field some questions from online. Yes.
This question for Dr. Single, but maybe for the panel as well. So early transplant for alcoholic hepatitis is already controversial enough. Now that we have MET ALD in the mix, my documentation always very careful with this population, right? Because you check for PET level, and for example, even with MET ALD, you check a PET level, it can be positive, and some might argue the level may be different in this population, but it's the timing of the drinking and timing of testing. And MET ALD is still kind of heterogeneous. Where do you see MET ALD patients in the selection process for liver transplant?
So the shortest answer to your question would be probably we don't know. Because it's a new disease based on the nomenclature which came 3 years ago. So we don't have much experience with MET ALD group. If you define MET ALD based on the alcohol amount which is suggested by that new criteria or new nomenclature, or by PET level between 25 and 200, which is suggested to be the MET ALD cutoff. I didn't go over that because we don't have much experience there. The one study which people from UPenn tried using the UNOS database, and thousands of patients, but then they selected 100 patients from UPenn, and you can do that asking the UNOS to identify their own center patients, and they went into the chart, and using that new definition, they could come up with a definition of MET ALD. So I think going forward, in prospective studies, we may have more information, but what they showed that the MET ALD, waitlist mortality and post-transplant outcomes comes in between MASH and ALD. ALD has the best, MASH is on the top, MET ALD is in the middle.
So with the MET ALD definition in mind, when you say the table to select patient for liver transplant, would that make any difference for you in terms of choosing? Would that something in the back of your mind that you said, maybe I should give this patient more benefit of doubt?
I don't think so, because unless panel has a different opinion, because as we saw, the case selection on where alcohol plays a role is more on psychosocial assessment than the medical eligibility. Medical eligibility decision on yes or no would not change what etiology is. So in my mind, even MET ALD, it'll be more on psychosocial assessment.
Thank you.
Hi, this is Cedric van der Bruane from Belgium. I have a question for Professor Dunn. So you stress on the fact that we should use resmetirom in fibrosis. However, next week on the EASL, there will be data as well on compensated cirrhosis. Do you think this will change your approach to these patients as well, or don't you think this will be a game changer?
No, yes, I'm aware of the presentations that will be on that there will be improved in fibrosis in patients with cirrhosis. However, the current FDA approval is important to emphasize. It is still for patients with stage 2 to 3 fibrosis. And as I pointed out, if you inadvertently, because your intentions and what you actually enroll, it is always going to be different. If your intention is to enroll patients with F2 and F3 fibrosis, you will inadvertently include patients with cirrhosis. And if that is the case, they are safe and may receive additional benefit. If your intention is to include patients with cirrhosis, which is clearly against the FDA guideline, with compensated cirrhosis, let's say, you will inadvertently include patients with decompensated cirrhosis, because you cannot have a surgical precision. And in that case, you will be in area where there is clearly no any evidence of safety data. So only include patients with F2 and F3 fibrosis.
Thank you.
Okay, we have a few questions online for Dr. Jasoudian, so I'll just pick a couple of them. The two that I'd ask are, first, what are the common side effects of the PPAR medications? And second, do you have an opinion about the use of fibrates for patients with PBC with incomplete response to URSO in areas where the new drugs haven't been approved or maybe too expensive?
Yes, the PPAR medications generally are very well tolerated, and GI side effects are among the most common adverse events, but very rarely led to any discontinuations. When it comes to fibrates, I think at this point in the U.S., in terms of FDA-approved therapies, we have two new ones that we just reviewed in the arsenal. So I don't think we need to go outside of the FDA-approved therapies for second-line treatment of PBC at this juncture.
Yes.
Thank you. Hello. My question is to Professor Singhal. Regarding the NACLF, and specifically CLF3, you mentioned few criteria, and the bottom was that the performance or the functional status, which you showed this moderate to good one. So is the performance status before the onset of ACLF or during the ACLF? Because
yeah, that's a good question. So if somebody was walking up until decompensation, or had a good status and now is in the ICU, it still would be a good candidate. But if somebody was not able to maintain a good performance status right before the admission, that's where you have to be very, very clear in making that decision. But as I said, there is no evidence behind it. Typically, if the patient is in ICU and if it has been 7 or more days in the ICU, then you have to be a little bit more careful taking that baseline because you never know how much muscle he has lost in the 7 days. And then that could be a significant issue post-transplant.
So this brings us to that the pre-ACLF, probably the patient was in a decompensated cirrhosis and now has an additional
Right.
ACLF.
Right.
And that's where the apostle and the
Correct.
the Europe would differ.
Correct. Like this becomes a more important issue in patients, say for example, who comes in the ICU infected. Okay, now we're trying to get the infection cleared, having blood culture, having TEE on the patient, make sure there are no vegetations and things like that. It passes like 10 days already, and now you have the negative blood cultures, and you meet those criteria. Then the performance status, you have to be a little bit more careful in making a decision because you may have lost significant muscle mass in those 10 days.
I think we have time for one more question.
Yes, it's a question for Dr. Arun. In Mexico, we don't have elafluronor, but we have fibrets. You think it's a good data to use besafibret, for example?
Yes, so certainly even before the FDA approval of these PPARs here, fibrates have been used off-label in the second-line treatment of PBC, and so it's certainly worth looking into the existing literature that is out there. And so again, here in the U.S., I wouldn't really advocate for it. There's no need. But if you don't have those available to you, then fibrates can potentially be used, with some efficacy as a second-line therapy in PBC here in the U.S. off-label.
Well, I'd like to thank my co-moderator and the speakers for an excellent session and the audience for asking some very insightful questions. Thank you.